Good afternoon and welcome to today's webinar. This is Joan Blau and I am a Build Initiative consultant and supporting states in the lead up to the submission of the PDG Birth to 5 applications. We're thrilled at the interest in today's webinar and extremely excited for the opportunity for all of you to have the benefit of Ms. Chang's expertise related to partnering with Medicaid. Debbie Chang is the Senior Vice President of Policy and Prevention and a Corporate Officer for Nemours Children's Health System. She works to leverage Nemours' expertise and experience to spread what works through national policy and practice changes to improve the health and well-being of children nationwide. Prior to her current position, she served for 13 years at the federal government working on Medicaid and CHIP policy. And prior to that, she was the Medicaid director for Maryland for 5 years. I am going to turn the webinar over to Debbie at this time so she can talk to you a little bit about what our agenda is for today and what she hopes to share with you during our time together. Debbie?
Thank you very much, Joan. I'm really delighted to be here today, and that was really a kind introduction. And let me move to the next slide, which is our agenda for today. So I'm going to start with, why do we even want Medicaid and CHIP at the table? And a little bit on how the Medicaid and CHIP programs work. I might go through that rather quickly because I know what's really important to most of you on the phone is the strategies for how to engage Medicaid and CHIP programs, and to give you some concrete examples of collaboration. So with that, let me go to the next slide. I think we're first going to do this poll with 2 questions. And
yes.
The first one is my state's Medicaid agency is a key partner in our Birth to 5 early childhood state system. We just want to get a sense of where folks are, so we thought this would be a really good question to ask. I'm going to ask Joan exactly what do I just skip to the results, Joan?
We're going to want to go to the next poll question, but I want to let people know, it's already in the chat box. To see the results, you have to answer the poll. So please take just a moment or two to answer the poll. And
Joan and Debbie, you can just click skip to results to see the results.
Oh, right. That's right. Okay. So it looks like, I'm sorry, it looks like over 50% are saying that Medicaid's already a key partner in your early childhood state system, which is great to see. There's a strong but mighty number that disagree, and then there's some that aren't sure. Okay, so then let's go. Oh, guys, there's more people responding. Okay. Give it one more moment. So still, significant number of you that already are working with your Medicaid folks. I'm going to go to the next slide. Is that all right, Joan?
Well, what I would say, Debbie, is I do think that it's interesting that about half the people who responded said they're not sure. So perhaps when you're in the webinar, you might suggest some ways for people to find out what kind of partnerships might actually be going on right now related to their state Medicaid agencies after this call.
Yeah, that's a great point. So next slide, we have another question to ask you all. My state's Medicaid agency is engaged in the preparation of the actual grant that you're all working on. I'm going to skip to results just so we can see people's results. Give everyone a few more minutes. So a really significant number, about 75% at least at this point, it's changing a little, 70 to 75% are saying, okay, I'm going to wait a minute. close to 70% of you are saying that your state Medicaid agency is not involved.
Mm-hmm.
But a third of you are saying that the state agency is involved. So that's good to hear.
Mm-hmm.
At least if there's 30%, but there's a significant. So this is why this session is needed.
Absolutely. And, of course, there's always opportunity to still engage folks, but even after grants are submitted and received would also be an opportunity. So I know you'll be touching on possibilities for engagement as you go forward, Debbie. So thank you.
Good. That was really helpful, everybody. Thank you, guys. So this is just a little bit about Nemours. You're probably wondering what's Nemours. Part of us is the huge pediatric clinical system that operates in Delaware Valley and northern central Florida. But the part that I oversee is our national work to really improve child health and well-being across the country with a special focus on the other determinants of health and really trying to integrate our clinical systems with our, with the population health systems that support children's overall health and development. So we're more than just a clinical enterprise. We really focus on, population health and prevention. So let me go directly to why. Why do we want Medicaid and CHIP to be a partner? So this is for maybe the 60% of you that don't have Medicaid at the table. The first and most important is we really serve Medicaid, and who you're serving is the same group of kids that are being served. And in fact, 45% of children under age 5 almost are served under Medicaid, and almost half of all births are covered under Medicaid. So Medicaid and CHIP are really a huge factor in working with the same age group that we're talking about here. Just overall, children constitute half of Medicaid's enrollees. But it's important to note that while it's half of Medicaid's enrollees, it's probably about 20% of overall Medicaid costs, which is why sometimes it's hard to get states to focus on the Medicaid on the child population because it's a much smaller percentage of their overall costs. Things that are driving costs in Medicaid are nursing home costs, long-term care costs, the chronically disabled. Those are the kinds of things that are driving costs for Medicaid. It's also important to note that Medicaid covers services that link beneficiaries to social services. So case management that can link a Medicaid child to SNAP or to child care or to legal services. So kind of care coordination and community care coordination, those kinds of things are actually covered under Medicaid. Obviously a core mission of Medicaid and CHIP is to provide health care coverage, but I stress this, partnering with others that serve the child population ensures that the health and ECE, early care education resources are better coordinated. Let me pause there and see if there are questions on this first slide, because then I'll go into a section much more about, well, what is Medicaid?
So if anyone has questions about why it's important to invite Medicaid and CHIP to be at the table, please feel free to enter them into the chat box now. And we're just going to pause momentarily. We can also come back to those questions. But when you imagine yourself really needing to talk to others about why it's important to engage or include Medicaid, if there's other elements that you would like for Debbie to cover, please let us know in the chat box, and we'll bring that up as we go. So seeing no questions, Debbie, I think you should go forward, and we'll pause again after the next section.
Okay, so this next section is about understanding Medicaid. And I'm going to go through this relatively quickly so I can get to the strategies of how to work with Medicaid. First, Medicaid is an entitlement program. It's an entitlement program to the individual, so it's not a block grant program. It's, low-income children that qualify are entitled to the program. It's operated by the Federal Department of Health and Human Services, but it's really a partnership between the federal government and states. So feds set broad parameters. I'm going to go through some of that, but there's tremendous state flexibility. And as Joan said, I was a Medicaid director for 5 years and also applied when I worked at the federal level. When you've seen one Medicaid program, you've seen one Medicaid program. The state receives funding from the federal government to match state funds. And I want to stress, however, that state funds are really needed to get that, to draw down on that matching. So that's why getting a state to focus on it does result in additional dollars coming from the state, even if the match is occurring. And the match varies anywhere between 50 and 70, as high as like 75, 78%. But even at that high match, you still have to have a contributing state match, which is why that you've probably read in the papers that whether some states expand Medicaid or not is an issue because of that requirement for state match. There is a wonderful preventive benefit under Medicaid called the Early and Periodic Screening, Diagnostic and Treatment Program, EPSDT, which covers preventive care and any medically necessary service. So the next slide is there's a lot of flexibility, particularly in the area of reimbursement. There's broad benefits, including EPSDT, which I just mentioned, but things like the drug benefit is actually optional, but I think all states cover drugs, obviously, because drugs are so critically important. And this is one thing we really wanted to highlight to folks is that while the state has the responsibility for running the program, often the state will delegate that responsibility to managed care organizations. So these are private plans that you all probably know of that that are more focused on managed care. 68% of children are enrolled in managed care, and what happens there is that the managed care plans are getting a fixed fee per child to provide the costs of the services. That's determined by an actuary. And if the costs are less than the child fee, actually the managed care organization gets to keep the difference. And theoretically, this is a way of ensuring that the most appropriate use of services occurs, right? Because if you were paid on a fee-for-service basis for every service, you might push out volume rather than focus on those services that are really essential. And also, by having this kind of flat fee, this creates an incentive for the managed care plan to actually focus on prevention, a lot of what you guys are focused on in this grant. The other 2 points are that that there is flexibility to cover certain other services under the Medicaid and CHIP programs. And you can even cover non-medical benefits, so supportive housing, case management, and even cover services by non-professional but otherwise qualified practitioners. And states are kind of just recognizing this flexibility that exists under current law. So by a couple of points there, by the term non-medical professions, that could include family support workers or community health workers that are certified by the state. And a lot of those folks are operating in different early childhood settings, and that's why I wanted to call that out.
Debbie, this is Joan. We've got a few questions. I'm wondering if we might take a in presentation pause and answer those so they're super relevant.
Sure. Let me get to the question part. Let's see.
Yeah. So one of the questions was you were talking about how Medicaid can help to cover linkages, and the question is, are the linkages supposed to be made through EPSDT and or care coordination? Are these the same thing? Can you elaborate on that a bit?
So usually what has to happen is, I'm trying to make sure that I complete the question, I'm sorry. Elizabeth's question went away. Let's see. Okay, there it is again. Okay. So what usually happens is to make those linkages, because Medicaid is primarily a healthcare program, when somebody comes in as a patient and needs these other types of services, That's usually the way the linkages happen, but they don't have to happen that way. And so it can happen from both sides. If there is a healthcare need or other linkage need that the healthcare provider notices, that should trigger the healthcare provider then linking to, these other kind of support services. At the same time, if there is if the issue is discovered by a family support worker, a community health worker, that is another way to make the linkage. But I would say, to answer your question, Elizabeth, that unfortunately the kind of flow practices don't actually work that way now, but nothing prevents any of you on the phone from developing a flow pattern that would allow for that linkage to happen, whether you find a need at a clinical center or whether you find a need in another early childhood setting. And so this question by Betty is really important right now, which is so it really depends on what state you're in and whether the state allows for what the question is about providing health services and screenings at an ECE location. It is possible for that to happen. So in the state of Vermont, there's a program where the clinicians have trained folks at the child care center to do the ages and stages developmental screening. That's a screening that screens for different developmental issues for children. And in that particular case, the screenings are paid for actually by Medicaid to in that situation, to the child care professional that's providing the screening. And that's because they allow that in the state of Vermont. So the state has to approve of this to do it. Now, having said this, nothing prohibits, there's nothing in the statute that prohibits a clinical provider from providing the service at an ECE location. There's nothing that is perfectly permissible under law. And again, you just have to have the state kind of recognize that. Does that help to answer those two questions? See, how does the Accountable Care Act impact this? So the great thing about the Accountable Care Act is that it does highlight in it the use of community health workers. And I think that's, so around the country now, there's all this kind of new group of professionals called community health workers. And there was provisions in the law that looked at further promoting the use of community health workers. But again, it depends on the state and whether the state is actually doing that. So for example, the state of Minnesota has spent a lot of time trying to credential its community health workers to provide services. That's an example. So it can happen.
Mm-hmm. Thank you,
okay.
Debbie.
Sure.
That was very helpful.
I've alluded to this already about state budgets that, Medicaid and CHIP together account for about 20% of the state general fund. That's second only to education and growing. So that's why, Medicaid's a big budget item and something that, the governor and your legislators, pay close attention to, particularly because they're trying to control costs. So often you'll hear about Medicaid in your state papers or from people because, your governor or somebody will be trying to control Medicaid costs. As I mentioned earlier, the cost of the benefits in the state budget, they impact the decisions on whether to cover benefits or whether to use different professionals because there's a concern that by using all sorts of different professionals and by, offering all sorts of benefits, it's going to increase the overall cost. So just to give you that as a backdrop. And, once a population or a service is added, especially if the federal government requires something, then, it's hard to eliminate it. But also I'll make a different point is when a state makes a move to expand coverage to optional groups or expand the different types of benefits, they know it's very hard to scale back on that later. And that's why that decision to do that is such, it's usually a decision that requires a lot of debate by, the state and the legislature. And the reason, just like in anything in prevention, the reason it's hard to get prevention to be focused on is because the cost savings don't come until a lot later. It's usually later in the budget cycle or during the next governor's term. And so that's why it's hard to get folks to focus on prevention generally and especially for kids. So then the next slide, and this slide is just about state priority setting, that it really depends on what's important in your state. States identify different priority health needs. Sometimes it's long-term care, sometimes it's children. It just depends on what's going on in that particular state. So I say here that, often the populations of children, they are a priority, and sometimes they focus on other drivers. As I said earlier, long-term care, nursing home costs, drug costs, those tend to be drivers. But I'll also make the point that state advocacy groups can really elevate issues for state action. And that'll speak to some of the strategies we have later for how to engage on Medicaid. We'll go to the next slide. The only other thing we wanted to say here is that, states are really cognizant of the demand for Medicaid and CHIP. So they look at things like the poverty level and unemployment rate. Those kinds of things would drive up the demand for CHIP and therefore the cost. So a state may, also resist expanding services if there's not enough qualified providers. So in the area of mental health, it's just a good example. Every sector that deals with young children is seeing a growth of mental health type services, both preventive and treatment. And I think the reason that a state might resist expanding some of these services is because we all know that there's not as many qualified providers, or even provider availability is a huge issue in this area. So the next few slides, I just want to give you a sense of where the head of a Medicaid person is. So when we're thinking about health and wellness and expanding to prevention, that right side of the screen is where the traditional medical model is, right? And the expanded view is the left-hand side, or the other way around. The left-hand side is the traditional model. The right-hand side is the expanded view. So we are, I think we are undergoing a transformation in our health system in this country where there's more of a focus on wellness and well-being. And what that requires is a shift from a biomedical view of health to a multifaceted view, from a focus more on acute to a focus on prevention and long-term management, from a focus on individuals to much more of a focus on communities and populations, and from a focus on cure to a focus on prevention, from a focus on disease to a focus on health. And when you look at that as a continuum, many state Medicaid agencies are in that left-hand side. They're still in this traditional clinical model. But there are others like Washington and Oregon that have embraced this, New York, that have embraced this kind of expanded approach. So that's just to give you a sense that Medicaid agencies in your variety of states, they're on, and they're on this continuum. And then I just wanted to make sure you knew that we at Nemours have developed a whole set of resources about, trying to highlight the current options under Medicaid. And there's a lot of flexibility under Medicaid to provide prevention. But because Medicaid directors are more on that left-hand side, that's why you might have to work with them and their staff to kind of understand the options under current law. And we have a whole toolkit about this, and I have in here the site where you can get more information on that. I'm not going to go into detail there. We did a follow-up study where we worked in 3 states, Maryland, Oregon, and Washington, to actually put in place or to operationalize and pilot some of these strategies. And so this is a whole bunch of information on that. There's a couple that I wanted to highlight for you in there. One is I'm sorry, I'm just trying to look at my notes here. There's brief, and let me just say that all these materials they were written with the audience in mind being a Medicaid staff or agency. So they weren't written in the, because I was trying to work with Medicaid agencies to get them to see the current flexibility. So that's the way they're framed. Issue brief number 3 is Medicaid and Head Start, for example. And then the idea of embedding, I wanted to bring up issue number 4 because here's a good example where we were working on embedding a Medicaid dietitian on site at the Early Care and Education Center, and that speaks to a question I think that Betty or someone raised earlier. And speaking of questions, I think there's a question, and let me see if I can. Yeah, it's a very good question, Rebecca. EPSDT is required benefit for all states, and it's a comprehensive benefit package that pediatricians, or other family serving practitioners are providing. Like anything you guys deal with this in the early childhood world generally, it starts with a screener, right? And then from the screener, you've got to identify and then refer folks to other services. I think that referral process, the screening and referral and kind of care coordination generally gets lost, and that's why, it's challenging for states to, implement EPSDT in the best way. I think the states that have embedded a medical home in their programs, like a primary care medical home, those with, certified medical homes, they tend to do better on EPSDT because that medical home concept includes the screening, the referral, the education, kind of the looping back to make sure that the patient actually got the referred service. These are big issues for EPSDT, and it's one of the reasons why states aren't as far along as we would like. I know that doesn't quite answer your question, Rebecca, in terms of, who is the best. I would refer you to the NASHP, the National Academy of State Health Policy website. They have a whole section that's about EPSDT, and they profile different states. The ones that I know that are profiled, that I'm doing from memory, I believe Vermont is profiled, and I'm pretty sure Minnesota is profiled. But if you go to that website, the National Academy for State Health Policy, it'll show you which ones are the best. Let me get to our next section because I think I'm just looking at the time. This is the key to what you guys really want to hear about, so I want to make sure I get to this. And then we'll still have hopefully some time for questions at the end if there are other questions. So we've been doing a lot of work in this space that I mentioned earlier, and so have identified 5 key strategies for working with your Medicaid and CHIP agencies. And we were lucky to get funding from the Alliance for Early Success to write a paper that looks at it from your point of view, not the Medicaid point of view, but from the early childhood point of view. That paper is, the contents of that paper are in this, much of it is in this PowerPoint, and you will get this PowerPoint. We're putting the final touches on the paper. We have a draft, and so if you really want a copy of a draft, I'm happy to give it to you, and you can just email us or me, and we'll get it to you. And just know it's a draft, and we hope to have that ready in the next 2 weeks. We know that doesn't meet your deadline for November 6th, so if you want a copy of the paper, by all means, just email me, and please know that it's a draft. So here are the 5 strategies. One is, I know this is probably obvious, but identifying a high-level champion within your state Medicaid and CHIP agency who really believes in improving child outcomes. So I'll give you a couple examples. I'm going to go into each, but a couple examples here. I have the privilege of working with Mary Ann Lindeblad, who is the Medicaid director for the state of Washington. She's committed to children, and so that's a good example. And I say that it doesn't have to always be the Medicaid director. In the state of Maryland, we're working with the state medical office, Medicaid medical officer. So it doesn't have to be the Medicaid director, but finding a champion is key. The second thing, and that's why we spent the time on the preceding slide, it's really important to understand your current state Medicaid and CHIP priorities and initiatives, so that you can, when you approach them, you can know what's important to them and know kind of where your issue stands relative to the other priorities that the state's working on. And that leads me to number 3, which is really important, which is to make the case for the partnership by focusing on shared goals and shared populations. So I'll go back to the Washington example for a moment because it's a good example, because Marianne has specific metrics related to the well child visit. And so one of the goals could be improving or increasing provider screening. And so, if you're going in a state that has, the need for the well child visit already on the metrics, right, already in terms of a goal that the state has already committed to, you can go into the office and say, I want to make sure you meet your goal of having child visits and doing the developmental screening. And so that's a much better way to approach Medicaid than just saying, I need your funding. Because that's what happens, having been a Medicaid director for 5 years. Every day I had someone in my office telling me, I need your money. I want you to fund this benefit, or I have this way of saving money for you, or, so it's better to approach the Medicaid people by saying, hey, I want to work together with you on our shared goals, and here's what they are. And so number 4 is also really important, which is kind of understanding the state's Medicaid program. And then the 5th one is it kind of puts it all together. We have found that in the states that we've been working in, start small. Start with a small initiative or a pilot program that is connected to the partnership goals. And then you'll start working with each other, you get to know each other, and it's a great way to build trust. So I'm going to go into each of these with some detail, but I also see there's a question. So let me... oh, by the way, there's a link here. It's not active yet because we're still finalizing the paper, but when the paper is final, that's where it'll be. Lori has a question. Are the care coordinators housed at the MC? Good. Very good question. It depends on the state. So a lot of my answers will be it depends on the state. Often, you're right, managed care organizations have their own care coordinators. But often those care coordinators are only working on coordinating the clinical pieces, right, because they're doing the primary care and the specialty. But there are also care coordinators that interface with the community. And actually this has been clarified in 2016, that under Medicaid, under managed care, Medicaid managed care can pay for what's called community care coordination, where there's a linkage between the clinical piece and other social non-medical services. In some cases, the MCO will house their coordinators at community organizations. So that's why it's important to know whether you're a state with a lot of managed care or you're a fee-for-service state. I will tell you most states have some form of managed care, and most states are fully using managed care. So it's likely that your state is using managed care. And there you have 2 things you have to do. You have to work with the Medicaid managed care people, and you have to work with the state Medicaid program. Lori has a question I'm looking at right now. Looking at this, does this imply that Medicaid could be billed for that? So if a number of things need to happen. If you're in a state that allows for Medicaid to reimburse directly dietitians, and those dietitians are working at schools, that should be reimbursable. But the dietitian would have to be a Medicaid enrolled provider. A Medicaid enrolled provider, there's two pieces of that. One is that you have to be a licensed, under your state laws. And the second is you have to be, often that means you have to be credentialed, or there's some kind of credentialing as a part of that. And then if you're in a managed care state, often the managed care organization has its own credentialing. So there are several steps to make that happen, but it is possible. So I think that answers that question. And I'm happy to take questions later on this as well. So let me go to the next slide. So here's just much more detail on the high-level champion. Obviously, having the Medicaid director really facilitates decision-making, right, because they're the decision-maker. But often the Head Start Collaboration Office could be a good place to negotiate partnerships. Building on what's already happening in your state is really going to be important. As I said earlier, approaching the stakeholders for funding, that might be what you want to do, what you want in the end, but that you're not going to get there by starting there. So it's really important to establish a relationship based on shared concerns. And we have seen success when a partner connects their initiative to what's already a Medicaid or CHIP priority. That is key, because then you're helping each other. It's a win-win. So that's that slide, and then I'm going to go to the second thing we talked about, which is understanding the current priorities and initiatives. So I kind of referred to this earlier. It's much easier to build into existing Medicaid and CHIP initiatives. So, for example, in the state of Maryland, there's a whole effort underway in the state to focus on population health at the local level. And so trying to understand what's happening in those initiatives for kids in the state of, I happen to know Maryland because that's where I was the Medicaid director. They, we use local health departments to do a lot of our outreach in the community, including with outreach to children. So that would be a good place in this example to explore, early care, early childhood strategies. And for example, we have an example here that, you embedding it on an existing waiver instead of pursuing new waivers is the way to go. So if you know in your state that they're pursuing a waiver already, that might be an opportunity. And we didn't go into this in detail before, but the slides referred to it. There are also federal priorities that occur. And right now, the federal government has stated that it is very focused on state flexibility, and in particular interested in community engagement or work requirements. And in fact, there are lots of waivers that are being explored related to that. And so that might be a place where you can embed some of your strategies, or at least get an ear about an existing waiver that's going through. It just depends on what the content of the waiver is. I'm just saying that because there are waivers that are being considered about work requirements, maybe there's other content that's also being addressed in those waivers. It's really important to look at the CHIP Medicaid data and to understand the health landscape, so you can see what's going on in your state. So if you know that your state is really interested in chronic diseases, all chronic diseases start in childhood. That's a finding of the last decade in particular, that most of these have these chronic diseases like obesity start in childhood. And so looking at in this example, your obesity trends, your BMI for children, or looking at your, the other data in your state about young children can help to build the case for going to the Medicaid office and saying, hey, we've got these rates that are really poor. let's try to improve them together. This is consistent with XXX that's going on in the state. I mean, that's kind of a way to approach it. It's really another important place to look is whatever quality metrics your state Medicaid CHIP folks are already looking at. That is, understanding that and the data collection related to that, that's a great place to start when you're looking at developing shared goals around overall child well-being. Okay, there's a couple of questions here. Yeah, well, so there's good news and there's more complicated news with your question, Gloria, and that is that if dental is carved out, that would mean you would have to go to the state, and it's fee-for-service, you would have to go to the state agency and talk to them about, you know, whatever you want to happen in dental. So in this example, the managed care organization probably doesn't do a lot on dental because it's carved out. Usually the managed care program will only focus on those things that are within what it covers, even though there's a huge rationale for having a linkage between the managed care plan and, in this case, dental. I would start with the state agency. And the other thing is if you can get the state agency's buy-in, ultimately the state can impose requirements in the contracts related to the managed care organization, or at least when an MCO knows that the state is focused on something, they will pay attention to it. So when they knew that in Maryland I was focusing on certain clinical measures for children, they focused on it. So getting your Medicaid agency to support what you're doing and then be a persuasive voice to the MCO, that's a good strategy. Is there any way to find information? Yeah, there's supposed to be a process, a public process. When there's any waivers, there's supposed to be like a public hearing for input. That's supposed to be the process. So if you go onto the CMS website, so I think it's, cms.gov, we can come back to you and get that website. You should be able to find out what's going on with existing waivers. The other way to figure that out too, Beverly, is the Kaiser Family Foundation. They do a great job. They have basic information on every state Medicaid program and CHIP program. And they also have up-to-date news about existing waivers. So that's another source, Beverly. Okay, I want to try to get through these slides. I only have 15 minutes, and I haven't got through examples. So I've gone through some of this before. Emphasize, you get the message. Focus on your shared goals. And like home visiting programs, right? The whole goal of home visiting is to ensure that children receive immunizations and well-child visits. That's also a goal of Medicaid and CHIP. Then Medicaid, this answers the question that was also talked about earlier. The Medicaid managed care organization, they're more likely to have a care coordinator focused on complex medical needs rather than the kind of primary care needs. And so you could have the ECE program rely much more on the MCO case management for complex medical conditions, and then the ECE or early childhood programs could focus more on the less severe or more moderate cases. That was our example there. Clearly, if there's a legislative leadership, or if the governor or the lieutenant governor, if they care about children, that's a great place to look for facilitating a partnership with your state Medicaid agency. The next one is understanding the structure of the program. I've talked a lot about that. I do think it's really important to figure out if the managed care programs in your state, if you're in a state that has managed care. Also, just so it's important on this fourth bullet to understand the process and timing of adding requirements to state contracts. Usually it's a 1-year process, and the state will start working the last quarter of the previous year, so right about now for next year, or even before now, to figure out how to incorporate new initiatives, but each state has their own cycle. Let's see, I think I've mentioned all these. I'm going to go on to the next slide because I see we only have 10 minutes. And this was just you don't have to start big because it can seem really overwhelming to start big. You can start small. And so this idea of a pilot is a good way to start building trust and realizing that you have shared goals. So let me go to a couple more examples because we have about 10 minutes. So at Nemours, I mentioned the other projects we were working on. This is an outgrowth of that. We're now working in 3 states trying to better coordinate early child care systems with Medicaid. We're working in the District of Columbia, Maryland, and Washington. And we're developing a whole set of how-to brief from this, which we'll have by the end of the year, so that, that's a little too late for your application process. But to Joan's point, even after you're awarded, there's still plenty of opportunity to work with your Medicaid agencies. And in fact, Susan from Build recommended, and I agreed to do a briefing post-award as well, so that the states that are lucky enough to get the award can start thinking again about how to work with Medicaid. So we'll have some information on that. I thought it might be helpful to give you an example, for example, what we're doing in Washington, D.C. There, our pilot involves developmental screenings, because what we found out was developmental screenings is happening at child care centers, and it's happening at primary care, and the systems are not talking to each other. So we're now trying to eliminate, our goal is to eliminate and identify duplicate screening efforts, and we're trying to develop workflows that work in both directions. We're fortunate to work with Elizabeth in D.C. on this. We're trying to do it from both ends. So, if you're at a child care center and your provider does a screening, how can we make it easy for the parents then to take the results of the screening to the child care center? And then the child care center would know that they didn't have to do a screening because the screening's already there, done by the doctor. And we're trying to figure out that flow process. We're also going to try to figure out from Elizabeth's end or from the child care end, what's happening there and how can we change the flow process so that the child care center finds out or has access to what the child's doctor has already done, so that we can possibly prevent a duplication of a developmental screening. So that's some really nitty-gritty stuff that we're doing in Washington D.C. In Maryland, I spoke to this earlier. It's working on. We went through this entire process where we actually, the state had a state plan amendment which allowed direct reimbursement of the dietitian. We then worked with the managed care plan priority partners here and with the Medicaid with the Medicaid medical director to get that dietitian credentialed and enrolled as a provider at that managed care organization. We then worked with the Head Start agency to get that Head Start agency to accept having the dietitian on site. And we discovered a lot of things on this. Number one, we went ahead and did the screening. Oh, actually, we didn't have to do the screening. The data already exists through Head Start on a whole bunch of health information, including BMI. And the good news was that only 2 kids in that entire system of Head Start, it was Catholic Charities, only 2 or 3 kids had a BMI high enough that required additional work by the dietitian. The bad news was that there was only 3, and the dietitian lived way far away, and so her coming just for those 3 children did not make it economically viable for her. So that's just a good example of what we learned in that process. We also learned that Head Start has its own dietitians, and so we learned a lot in that process. I see there's a question here. What are the child-level outcomes we could expect to see as a result of better coordination and collaboration? Okay, the child health outcomes would be increasing developmental screenings would be one child outcome.
Well care visits.
Increased number of well care visits. I want to say to everyone, I've been joined by Julie Schul, who is our Director of Early Childhood Programs here at Nemours, works with me in the national office. Trying to think of other child outcomes. I mean, ultimately, by identifying the, I think you're going to want to have more proximal measures, Elizabeth, because, so I think increased developmental screenings is a good one. You probably will have increased immunizations, I'm guessing, and then increasing well visits. You know, if you looked, 5 years down the road, you might have other improved outcomes, of child wellness, but that's probably not, that's probably too far down. Let me go to the next slide here.
Another one I think you could do is something around coordination of family support plans. A child that is in Head Start and is also in Medicaid and has complex medical needs, or even is managing a condition like asthma, is likely to have several care plans, which is not efficient or effective and unlikely to produce the outcomes we would want. So I would say another outcome, Elizabeth, would be coordination around family support and care plans for children, so that you have everybody working off of one sheet of music versus multiple documents.
Washington's is very similar, so let me go to this next page because it'll give you other examples. I actually mentioned the Vermont one. There's a whole interagency developmental screening task force in Minnesota. Again, this issue of screening has been key. Healthy Beginnings in Atlanta. This one is not funded by Medicaid, but could be, so we might be working with them later. but they do have this nurse navigators that are hired by the Children's Hospital of Atlanta that work on site that help the families access services. And here we're talking about not just clinical services, but actually social services like housing support, transportation, other types of things. And I think I had one more slide. Great. Okay. So I went through that very quickly. We can take some other questions. And Joan, I don't know if you have some other things you wanted me to highlight.
Yeah, let's have, if folks have other questions, that would be great to go ahead and get those in the chat box now. But Debbie, I'm wondering if people really are, at the very, very beginning of the process, those folks, the 50% on this call who said they don't know how engaged their Medicaid agency is, what do you think are the most important first steps that they should really take?
Yeah, I think the first thing is to find out about what's happening for children in your state's Medicaid program. Mm-hmm. And you can do that by in several different ways. You can go to some of the websites I mentioned earlier, and we can follow up with what those websites are, but you can go to the National Academy for State Health Policy website. You can go to the Kaiser Family Foundation website. There's descriptions about, various programs. But I think you're really going to want to get your state slant on it. So you're going to want to go to I think the first place to go is your state website. And get a sense of where your governor is on this, on Medicaid, and what the priorities are for your governor. When you go on your state website, I think you'll get some information right away about what things they're working on. What are the initiatives of the state Medicaid programs? Often a state will have that, in their website. And so that's a great place to start. is to really understand what is the state doing in its Medicaid program.
It seems like, because of the way that the PDG B-5 grant is structured, it's really asking states to examine, do a needs assessment of their current early childhood system and really understand the early childhood landscape. It seems to me like you were suggesting that that's really an important part of the whole process of becoming more connected and building stronger partnerships as well.
I think that's, yep, go ahead. I'm sorry, go ahead.
I was going to say, including Medicaid in that process, like that might be a way to enter into something very, very specific that a state could do completely related to their grant application once they're funded.
Yeah, and the other thing I've discovered in working with Debbie is that Medicaid has a ton of data. And again, it's a great area for partnership that kind of stays away from funding, which is, tell us what you know about the health of low-income children birth to 5 in the state, because they've got amazing data. And again, it's not something you probably want to ask at your first meeting, but that's a good partnership to develop so that you can begin to have access on data across the state about what are the health issues that children are dealing with, what are your challenges around well care visits or around EPSDT screenings. So I think the partnership around data, too, fits really well with the needs assessment requirement for the preschool development grant.
Thank you.
I think the other thing I might want to there's a question, but let me also just add to what Julie's saying. What it made me think about is that lots of times Medicaid folks, just like all of you, are just running from meeting to meeting to meeting. They're just strapped. They don't have the attention. They're just so busy that they can't focus on this. So to the extent that you all can, take the initiative or this grant that you'll get provides the funding for you all to kind of take the initiative to gather the data and to do this strategic planning type work that Julie and Joan were just referring to, that will help with the engagement of Medicaid. I meant to say that earlier, that the reason we've been successful in working, with the states that we've worked in part is because we try to do it for them. We provide technical assistance where, we of course need to work with them with the state staff and everything, but we're kind of we kind of roll up our sleeves and our little bit of extended staff for them. And that's really helpful from a Medicaid perspective. If you're giving them one more thing to do, it's going to be hard to get them to do it. But that's why it's also important for you to integrate it into what they already need to do because of the state's priorities. Let me try to get Beverly's question before we need to end. Talk about how Medicaid funds serves like therapeutic child care for children needing behavioral, so again, it's the state's decision what specific behavioral health services they will cover. So it sounds like this is unique to Vermont. It sounds like a wonderful program, by the way. So, I think you need, but Vermont has a huge, long history of focusing on children's health that dates back maybe 30 years to Dr. Dinosaur, because when Dr. Howard Dean was governor, he focused on children. So there's a long history there. So hopefully you'll have an open ear from someone in Vermont's Medicaid program. They also have a very innovative overall Medicaid program generally that is focused on wellness. So they should be interested in what you're talking about, Beverly.
I think there's also some innovative work that's going on nationally, and I think 0 to 3 can help with this, but on Medicaid funding for Help Me Grow, which is a model of embedding specialists within pediatric care practices to help families access services and help them access mental health services. And I know 0 to 3 is working hard at helping states figure out how to access Medicaid funding for Help Me Grow referral program. So, and I think that's also something that happens in Vermont.
Well, with that, I think we are going to bring this webinar to a close. I just want to thank you very much, Debbie, for your great presentation and the wonderful answers you provided to questions. And I think lots of insight for folks and links to other resources, and we'll follow up to get those to people. And we appreciate everyone who participated in the call. And as we said at the top of the call, we'll make sure to send you these slides. And this webinar has been being recorded. We appreciate your participation, and we hope that you will be able to incorporate this information that you've learned today either into your PDG B-5 application, or once you're funded, that you're really thinking about how you can partner and engage with Medicaid to improve the health and well-being of your state's children. So thank you very much, and good afternoon.